Welcome everybody to our panel session on practice. Thank you for joining us this afternoon. My name's Kate Thorndike. I'm a specialist transplant pharmacy technician at Addenbrooke's Hospital. I had the privilege of joining the Kampala-Cambridge Health Partnership last year in September, and I hope to be able to use my research for my Global Health Masters to contribute towards developing that partnership. Just as we begin, if you could keep your videos off and yourselves on mute while our panelists are presenting, we'll have an opportunity for a Q&A session at the end of the presentations, where you can turn your videos on and unmute yourselves as and when you want to ask a question. Can I encourage you to put your questions into the chat function as we go along so we know who to direct those questions to? So it gives me the privilege to welcome our panelists and introduce our first panelist, who is Edwin. Edwin is a pharmacist and a recipient of the Chief Pharmaceutical Officer Global Health Fellowship. He is currently completing his PhD at the Liverpool School of Tropical Medicine. Welcome, Edwin.
Thank you, Kate, and thank you, everyone, and nice to be here. Right. I'm just going to share my screen with you all. Evelyn, is there any chance you can authorize screen share for me, please? Perfect.
Is that working now, Edwin, or do you want me to...
No, it's working now. So yeah.
Great. There you go.
Right. And does that show on everyone's screen okay?
Yep, we can see it fine. And I don't know if you want to turn your video on as well, and then we can see you at the side.
Yeah.
Excellent.
Hopefully no data behind me that I need to cover up. Right, okay, sorry. Hi, everyone. My name is Edwin Panford-Quainoo, and like Kate said, pharmacist by profession, and recently completed the Chief Pharmaceutical Officer's Global Health Fellowship. And I'm also doing, completing my PhD in Global Health at the Liverpool School of Tropical Medicine, and also teaching on the MSc Global Health program at the Liverpool School of Tropical Medicine as well. So I'm just going to present to you all about the part of my project, which was the Commonwealth Partnership for Antimicrobial Stewardship in Ghana. And I'm just going to give you a brief overview of what we did in Ghana. So the aims of the CW PAMS as a whole was to support partnerships to learn from not just from the UK, but also the host country, and to highlight existing international expertise in antimicrobial stewardship, and to help partners gather data both ways, and also offer support in any future schemes. And for us, I don't know if anyone overheard it, but for us during this COVID period, that partnership has even strengthened in one way or another as well. It was also set up to support pharmacists, and one of the stipulations of this partnership was that there has to be a pharmacist on either partners that were linked. And the project itself took place in 4 African countries, Ghana, Tanzania, Uganda, and Zambia. And mine was one of 5 projects that took place in Ghana. The partnership that I was part of was between the Ghana Public Health Association and the UK Faculty of Public Health. and in particular the Africa Special Interest Group. It was a multidisciplinary team consisting of healthcare professionals with various skills, leadership, management, as well as data collection and presentation skills. There were actually 2 pharmacists on my on the faculty's side. There was myself and Indu, and Indu is a specialist antimicrobial pharmacist working in Manchester. So this is the crew that actually went to Ghana in June. So we had 2 trips to Ghana, one in June and one in November. And this was a picture taken in June. So what the goals for the partnership was to establish and evaluate a functional model of antimicrobial stewardship, to try and create LECMA or help support LECMA to become a center of excellence for antimicrobial stewardship, and also strengthening systems and processes for stewardship through improving surveillance work, sustainable capacity, and workforce capability. So a little bit about Ghana and LECMA. So Ghana has a population approximately of 30 million. It is fairly young in structure in terms of age, and 57% of the population, according to the last census, were under the age of 25. Fertility remains high, particularly in the north compared to the south, but with the exception of Greater Accra region. So on this map here, the Greater Accra region is the one that's been kind of highlighted, and LECMA is within the Greater Accra region. So LECMA is actually called Lezekuku Krowo, and they've shortened it to LECMA, and the hospital is the main hospital in that municipality. The approximate male to female ratio for Ghana's population, once again, according to the last census, was 51 to 49 male to female ratio. LECMA itself, LECMA Hospital itself was established in 2010 between the governments of China and Ghana. It has a 141 bed capacity, serving approximately 260,000 population. But what we found when we were there was that some people do attend the hospital from far wider than the LECMA region. So the amount that they serve could be, population they serve could be a lot higher than this. The hospital has 17 laboratories within the vicinity, and they're a mixture of private and public. And in the catchment area, they're mainly, especially the ones in the private sector, they were mainly staffed by scientists. And the hospital itself had 14 lab staff that were based in LECMA on a full-time basis. So what we adopted, we're going to call them qualitative and quantitative, but we did a bunch of exercises and presentations to actually support the hospital in stewardship. So one of the things we did was discussions and interviews with key members of staff, as well as the management team. We had quite a few meetings, both with external stakeholders and internal stakeholders. And we had lots of observation, especially when we first went there in June, and supported them with making sure they did inspections and carried out a few audits as well. We also supported them to review their IPC and antibiotic prescribing guidelines. And we did a review with them of the patient notes. And that review of patient notes actually came as a result of one of the other things that we did. And we also took part in training of hospital staff both from the consultant level, senior level, to including some of the cleaners as well. On the quantitative side, one of the things that we supported them to do or to start doing is to carry out the global point prevalence survey. And that was actually what led to the recognition that the patient notes do need to be a bit more, need to have some more information than it currently did. So we then supported them through the outcome of this to look at what that should look like. We also carried out a knowledge attitude practice survey, which was conducted before the training and after the training. We also looked at the outpatient antibiotic prescribing, especially to look at the volume, as well as whether they were in line with national guidelines. And we did an analysis of hospital laboratory data to also determine some resistant patterns that were already coming through from the data that they had already given us. One of the things that we ended up by the end of last year supported them to the hospital to have achieved was an Ams Advisory Committee, and also supported them to agree terms of reference for the committee. By the end of last year, they had actually met twice, and the minutes were then shared with us to comment, and the plan, if it wasn't for COVID, was for us to actually have a live Zoom with on one of the meetings to then give our support that way, but COVID had other plans for us. The Gpps Global Points Prevalence Survey was done twice, one in June when we went, and then the second one was in November. And we have now got the results from that, which we're hoping to put together to present at a later date. The CAP survey has also been analysed. Similarly, we did one in June when we went, and then another one in November. And there are several training sessions that took place around infection prevention control, antimicrobial resistance, and stewardship. And with that as well, that we were given, participants were given a feedback sheet, and we're currently looking at analysing those feedback sheets as well. We helped support the Lekma Hospital to review its IPC guideline, including hand hygiene audits according to the WHO standards, and also reviewed their prescribing guidelines and made sure that most of the common conditions that they were coming across were in line with the standard treatment guideline for Ghana. And we also put together with their support as well, a one-page, what we call the antibiotic man, and they are currently looking to do an antibiotic child, which will be pasted around the hospital as well. And also with the lab, we've looked at ways of strengthening their AMR surveillance, as well as interpreting the data. And an Excel spreadsheet was put together by the epidemiologist on our team, which was shared with the team back in Lekma Hospital. And hopefully this year they will start sharing the data collected with us. And like I said before, the AMS committee was also established, and it's now still currently ongoing. One of the things that came out of what we did, especially in November, was to set up a trial of delayed or backup prescribing for upper respiratory tract infections. And with that, basically, we looked only at the OPD patients, and the delayed prescribing was ideally was meant to be for upper respiratory tract infections only. The data has been, also not the data was collected, and it has actually been published. So I'll put that in the chat room later on as well. But really what we were looking at was whether the delayed prescribing could be implemented. And we had the various schemes set up, 4 different schemes set up. And the outcome of this is that we show that it can be implemented in Ghana, especially, and possibly in many low middle income countries. Some of the key challenges was lack of resources to support and strengthen some of the basic infrastructure, such as infection prevention control, lab activities, and also staff development. The local community having free and easy access to a wide range of antibiotics. So for us, one thing that we tried to do, or we did, was to engage the community pharmacies that were within walking distance from the hospital in exactly what was going on in the hospital. Some of them did want to attend the meetings, but unfortunately couldn't, but we updated them on what was going on, so they were aware of the program at within the hospital premises. And also one of the major things was the overall lack of data and intelligence. But what we found was there were some data was being collected. It just wasn't either being published or used. So we've then had discussions on how these could be done effectively moving forward. And also difficulty in pushing things forward once the momentum was gained, especially after we've left the hospital or Ghana. So in conclusion, we were able to establish a functional and meaningful partnership, and the terms of reference for the partnership has now been set up for 3 years. So it will go beyond the terms of the CWPAMs. We are currently, we are currently working together in partnership, even within the COVID period, to look at how we could move some of the objectives forward as well, and to establish a functional and model for AMS, and continue making sure that LECMA is an excellent place for AMR and AMS stewardship. And finally, one thing that we are looking to do as well is to build the capacity and capability of the workforce in LECMA for not just prescribing, but also IPC practices as well moving forward. And finally, one of the things that came out of the CWPAMS project is that 16 pharmacists within the UK became the first cohort for the Chief Pharmaceutical Officer Global Health Fellows. And I know there's a Q&A coming up, so I'll wait for that session. Thank you very much.
Thank you, Edwin. We'll look forward to hearing more from you in the Q&A session. If anyone does have any questions, please pop them in the chat function. Our next panelist is James. James is a consultant medical microbiologist at Addenbrooke's Hospital. He's part of the Sorry, can you see me?
Yes, we can see you and hear you fine. I think Edwin needs to stop sharing his screen now.
Okay, fantastic.
You're fine, Kate.
Okay, perfect. James is a consultant medical microbiologist at Addenbrooke's Hospital. He's part of the ongoing health partnership in Uganda, focusing on antimicrobial stewardship and infection prevention control. Welcome, James.
Thank you, Kate. Thank you. I'm just going to start trying to share my screen. Can everyone see that? Is that okay?
Yeah, we can see it fine, Jamie.
Great, thank you. So as Kate said, I'm a consultant in microbiology and infectious diseases at Addenbrooke's, and I'm the Cambridge lead of the Kampala-Cambridge Antibiotic Stewardship and Infection Control Project, which is very much a multidisciplinary team, but which I'm going to talk to you about the partnership today, and also talk to you about how we've adapted in light of COVID and where we plan to take the partnership going forward. So this partnership really grew out of an existing partnership that was developed between the obstetrics team in Cambridge and Uganda. And that initially began as an academic collaboration with the University of Makerere, looking at the genetics of preeclampsia. And then it moved on from that to very much focusing on how to reduce maternal mortality, and was a well-established partnership between obstetrics in Uganda and in Cambridge. And as a result of this partnership, there's a recognition that infection plays an enormous role in much of the maternal and neonatal mortality in Uganda. And because of that, and also because of the funding call that has already been introduced in the first talk, we responded to that to try and develop this partnership with a focus on antibiotic stewardship and infection prevention and control, and take those aspects forward. And I think one of the key things to really emphasize is that, as was discussed in the first talk, this is very much a multidisciplinary team. So I'm an infectious diseases physician and medical microbiologist, but the partnership was had a lot of pharmacists involved, both in Uganda and from the Cambridge team, and Kay was part of that. And we also had infection control nurses as well as some junior doctors too. And very much a collaborative process and a collaborative effort. This is the hospital that we spent most of our time working at, which is Kawempe Referral Hospital, which is a hospital which is for maternal and neonatal medicine. And there's also this hospital, which is the Malago Specialised Women and Neonatal Hospital. And these are the two main hospitals in Kampala that worked on obstetrics and neonatal medicine. And they were the areas that we were working with. So what we did, so we initially went out in June last year to try and sort of work out exactly what was going on in terms of antibiotic use and infection prevention control processes on the wards in Uganda. And that kind of gave us a bit of an awareness about the needs that we needed to address. We also had the benefit, and you're going to hear more about this later in the session, of having some health psychologists as part of our team. And that was a really important aspect and a great strengthening aspect to our partnership, because they could help us guide how we can perhaps influence behavior changes and things like that when we're trying to implement new processes. So what we then did, we went back to Uganda in September and ran a course basically focusing on the principles of antibiotic stewardship and the principles of infection prevention and control. We then, with the aim that we'd be reviewing how antibiotic prophylaxis is used in obstetrics, we were trying to reduce the use of IV antibiotics, and we were trying to support and develop the development of medicines and therapeutic committees, which are the committees within the hospitals that develop guidelines about infection management. And these had been established a while ago, but they weren't meeting on a regular basis. So one of our aims was to try and support these committees and support the work that they do. So this is one of the slides from our training process about antibiotic stewardship, the general principles of antibiotic stewardship. And again, the audience that came on this session was a combination of doctors, nurses, pharmacists, and technicians as well as cleaning staff as well. So a whole multidisciplinary group of people were exposed to the principles of infection prevention and control and antibiotic stewardship. And these are some of the participants learning about hand hygiene. We used agar plates to see the normal flora on the skin of the hand before and after appropriate use of hand hygiene. We also hosted a group of Ugandan specialists in Cambridge later in the year, so in November of 2019, to try and share some of the things that we were doing within Cambridge related to antibiotic stewardship and infection prevention and control. And this is one of our infection prevention nurses, Christine Moody, who's a very vital part of the partnership, taking people around Addenbrooke's Hospital on a sort of infection control tour of clinical areas to see the areas that needed to be focused on. So we had, it was very much a two-way partnership. So we hosted a group of people from Uganda within Cambridge to try and share the learning that was going on. One of the things which is really important to say is that I'll just go back to the last slide. So many of the participants from Cambridge developed enormously from being part of this partnership, which was very beneficial when we moved into the COVID dramas of 2020. This is the microbiology laboratory in Kawempe, which unfortunately wasn't a really active laboratory. It had a lot of equipment, a lot of space, but not much action. And one of the aims of the partnership, before things were put on hold, was to really try and support microbiology developing within this hospital, so it could be used in a more, what they do currently is send samples to the university laboratory, and this is leads to very delayed results coming through. And we wanted to try and develop microbiology locally, and this is a part of the partnership that we want to take forward as we try and develop things and grow things into the future. So our plan really was to secure funding to continue the partnership. We wanted to collect the data that we'd already started collecting about antibiotic consumption pre and post the course. And we wanted to try and establish the global PPS survey that was mentioned in the talk about Ghana. And as I mentioned just now, we wanted to try and support and develop diagnostic microbiology and also build in a research element. Many of the doctors and clinical staff in Uganda were linked to University of Makerere, and we've got academic collaborations within Cambridge that we wanted to try and forge links in that area. However, as we all know, in December 2019, a patient was admitted to hospital in Wuhan in China with what was then a mysterious viral pneumonia, and everyone's life changed majorly. And this has led to things being quite different within our partnership. But as I'll try and discuss, we've hopefully, some of the things that we've developed within the partnership and the relationships that we've forged have been strengthened. And when we go forward into the future, I think things will be stronger. These are just some case count numbers of coronavirus in Uganda. So these are curves that we're all very familiar with, slightly different dates, but similar curves seen around the world. So coronavirus is a big problem within Kampala, less of a problem in the rest of Uganda, but it was causing a major concern to health workers throughout the city, as is understandable. And this is a context where where staff don't have reliable PPE, and infection prevention control measures are often not implemented as well as they should be. So we applied for some additional funding from THET, the Health Worker Action Fund, which we secured some additional funding, which helps support our partners in Uganda to procure scrubs, to help the pharmacists develop alcohol gel in-house, which would really greatly enhance the hand hygiene measures that we were trying to put in place. And then we also shared what we were doing in terms of COVID learning within Cambridge with our Ugandan partners, and they were very much part of our webinars and regular Zoom discussions that we had. And what we kept doing throughout the partnership was have regular contacts with our Ugandan partners, normally via Zoom or on FaceTime, to try and work out what the issues that they were facing and see whether we could help or whether we could share things which were going to be helpful with us. And I think it's really important to emphasize that we in Cambridge benefited enormously from this as well, because I think that it was very helpful to us working in Cambridge to kind of realize that it gave us a much bigger perspective about what was going on. And I think that myself and colleagues found this very, very helpful, that we realized that, you know, we're just part of a much bigger picture, and it was very important to be part of that. It was something which gave us a lot of strength, I think, with the work that we were doing. So obviously this had a major impact on the work of our partnership that we initially were hoping to wrap up in the early part of this year. So delayed visits, we were meant to go out to Uganda in March to try and finish the data analysis and data collection off. And many of the activities that we'd initiated were put on hold. However, I think that, as I mentioned in the previous slides, I think the whole process of COVID has kind of brought the partners closer together in many ways. So this quote that we've often seen, physically distant but socially connected, I think was really very true for our partnership. And I think that the relationships have got much stronger through this process. And I just got to put a quote here from Ronald, who's one of our pharmacy colleagues in Uganda, who basically said that COVID-19 has instilled a behaviour change in our patients and staff on the importance of using alcohol gel and mitigating the spread of infections. The local production of alcohol gel and the installation of the dispensers within our joint partnership was a timely blessing to us as a hospital, because we couldn't imagine, if they weren't in place, how difficult life would now be. This existence has built confidence and reduced anxiety among the healthcare workers. And I think, as Musa, who's the obstetrician, who's the Uganda lead of the partnership, also said that infection control is now very central in the importance of the hospitals working. So at the directorate level, issues which were perhaps sidelined previously are now seen to be centre stage. And I think that antibiotic stewardship is also a very important part of this. We know from our work in Cambridge is that we can get antibiotics can be misused in terms of COVID. So it means that we need to keep that aspect of the partnership absolutely central too. So going forward, we really plan to build and develop this partnership on the original themes about infection prevention and control and antibiotic stewardship. And I think, as I mentioned, we've now got clear awareness of the importance of infection control. And through the adverse effects of the partnership, I think we've got stronger links as a result of that and firmer foundations to build on for the future. We want to keep these aspects of infection prevention control, antibiotic stewardship. We want to maintain the mentorship and mutual learning, which has been such a strength over the last year and a half. We've been very privileged to have our health psychologists involved with this partnership, and we really want to keep that involvement going forward. As I mentioned, we want to develop the diagnostic microbiology services within the hospitals we work with in Cambridge, within Uganda, and build the research components, which I think will aid the collaborative efforts going forward into the future. In addition, within the East of England, we're hoping to develop global health fellowships for specialist trainees of different specialties. And it would be great if these in the future can be involved with this partnership. And that's the end of my talk. I look forward to taking questions in the discussion later on.
Thank you so much, James. Our next panelist is Atiya. Atiya is currently a psychology lecturer at Birmingham City University. She has worked as a behavioural psychologist in Uganda as part of the Change Exchange programme. Welcome, Atiya.
Thank you. I'll just share my screen. Right, can you see my slides?
We can see your slides, we can't see you, Atiya.
Oh, if you just bear with me, I will pop my video on. Right, there we go. Okay, and now I need to reshare. Okay.
Sorry, thanks. Thank you.
We'll get there.
There you go. Perfect.
Lovely. Thank you. So I'm going to build on what Jamie has just shared with you, but I'm going to narrow the focus somewhat, and I'm going to talk about the role of behaviour change in antimicrobial stewardship, and this is specifically within the context of the Kampala-Cambridge Health Partnership. So, as we know, antimicrobial stewardship is there's an element of complexity to it, because we know it cannot be explained by biomedical mechanisms alone. There is a huge human element to this. AMS involves a complex set of behaviours, so multiple actions are performed at different times. There's the role of adhering to guidelines, weighing up benefits and risks, decision-making processes in relation to lots of different elements across the care continuum, and importantly, it's an interprofessional effort as well. This doesn't sit with any one team. So it's very complex, and across all of these different behaviours, there are a number of influences that will vary both within teams and across different organisations. So there is no one size fits all to how we address this, and it really does need a tailored approach. And this is where the role of behavioural science can support. So behavioural science provides theories, models and methods which take into account contextual factors, organisational and also interpersonal determinants of behaviour to explain why people behave in certain ways. And again, there isn't one approach to addressing AMS and the behaviours associated with it. Rather, behavioural science offers a series of principles and a clearly defined process that we can follow to inform the design of behaviour change interventions. And in doing so, the interventions are likely to be context specific and as a result more likely to be effective. So I just want to share with you the process that we followed within the context of the Kampala-Cambridge partnership. So any attempt to change behaviour must begin with a behavioural diagnosis. We wouldn't prescribe a particular medication to a patient without first assessing patient symptoms. We would use a diagnosis as a basis for selecting the appropriate treatment, or the one that's likely to be most effective. And in the same way, we would do a behavioural diagnosis to understand which behaviours we need to change and why. And as a result of this behavioural diagnosis, we can define the problem more clearly, understand the contextual factors, and link them to very specific behaviour change techniques. And it all begins by specifying the behaviour. And quite often we talk about, needing to change behaviours, but it isn't always clear whose behaviour and which behaviours are being targeted for change. And so for any behaviour that needs to be changed, we need to consider with whom is that behaviour being performed? Who are the actors involved? Who needs to change the behaviour? Who is the recipient of that? What is the actual action being performed? Where is that behaviour being performed and when? And only then will we have that level of specificity that's required to intervene appropriately. And using this approach can also help in terms of a baseline measure, pre and post intervention as well. So I want to give you an example of how we've specified some of our behaviours. Within our partnership, we identified several behaviours. I'm going to share just a couple in this presentation. But we recognise the importance of staff needing to query prescriptions that were not in line with guidelines. But in order to be more specific, because of course there are lots of different staff members that will need to query it, but in terms of whose behaviour we were trying to change, we recognised that it was the pharmacy assistant or pharmacist, they were the actor, that would need to identify, and when they identify a prescription for an antimicrobial which isn't in line with the national guidelines, so that's the context in which this behaviour is happening, that they will speak to the prescriber, and that's the action, and target immediately. We have added a time frame to ask them to check the national guidelines. And being able to be precise, again, it makes it clear what the expectations are. In addition to specifying behaviours, we also need to explore influences on behaviour. And as we know, behaviour occurs in sort of wider social and cultural contexts. Prescribing etiquette, the unwritten rules of what happens on the ward, may override policy and guidelines. And so by understanding and exploring these wider influences, we can understand those barriers and facilitators in a little bit more detail. And this behavioural diagnosis is facilitated by using theory. So our theoretical understanding of what influences behaviour can then help us identify those barriers and facilitators. And the model that we used in this project was the COMBI model, capability, and this model assumes that for any behaviour to occur, an individual must have capability, opportunity and motivation. They are three essential drivers of behaviour. And so what we mean by capability is psychological capability. Do people have the knowledge required to carry out the behaviour? But also physical capability. Does an individual actually have the skills required to carry out that behaviour? Reflective motivation, or motivation in general, and all the cognitive, all the internal processes at play here. And reflective motivation is the process of weighing up pros and cons. It's this very conscious decision-making process that an individual will engage with. And automatic motivation is much more habitual. It's kind of behaviour that somebody might engage in without even really thinking about it. And then opportunity relates to the factors that generally exist within the external environment. So when we talk about physical opportunity, it's about whether the physical environment supports that behaviour, the behaviour that is required, but also importantly, social opportunity. So our social norms, those social influences are strong influences on behaviour, and they can affect whether somebody does or does not go on to engage in that behaviour. And again, according to this model, an individual needs to have the knowledge and skills, but they also need the opportunity, and they need to feel that behaviour is worthwhile in order for behaviour to occur. Knowledge alone isn't enough. There are other important influences on behaviour. And as a result, we can then target interventions to tailor interventions to target those influences. So just wanted to share an example of one of the behaviours that we identified during our initial scoping visit, and that was for all staff and patients entering and leaving the hospital to use hand gel to minimise the risk of infection. So when we did our behavioural analysis and we explored what some of those barriers were, we recognised that there were barriers in relation to lack of knowledge about the benefits of hand gel, and that staff and patients may not know how to use hand gel correctly. So those physical skills were lacking. In terms of motivation, people might forget to use hand gel as they don't engage in this behaviour routinely. And in terms of the opportunities in the environment, alcohol gel wasn't available during our initial visits, not at the scale that it is now. And there wasn't a lot of space on the wards for hand gel containers. And also in terms of social opportunity, it just wasn't the norm for people to use hand gel within the hospital, so you wouldn't observe other people engaging in that behaviour. In terms of solutions, increased capability, and these informed some of those the training that was subsequently developed, but it was very targeted. It was about increasing knowledge with posters and education about bacteria and the risk of infection. Also, trainees were given the opportunity to practice the skill, and they were provided with feedback on how to use hand gel correctly. Promote motivation. There were changes to the physical environment in terms of adding posters as a visual prompt to remind people. So to break that habit, to change what they do, unconsciously without thinking, with this visual prompt. And as a reminder to use hand gel, and then also changes in terms of making things more accessible, so increasing their physical opportunity as well. And we also, given the space issues, recognise that if credible sources, so senior staff, influential staff, carried small bottles of hand gel, then there would be role modelling the desired behaviour as well, and therefore increased likelihood of the behaviour change that we wanted to see. So I guess I'll share the evaluation with you, and then the role of behavioural science within evaluation also. But what we found was that the training did successfully increase awareness about the risks of infection. And here's a quote that we have from one of our trainees. So what I picked from the training was that helpful issue of hand washing, which we don't take so very seriously. So increased knowledge. Physical changes were underway, so the running water was always available in one hospital, but the soap and alcohol gel wasn't in place. After the training, those things were put in place, so we've increased people's opportunities. And then the third one, posters weren't ready at the time of the evaluation, but Jamie's presentation very nicely illustrates that they are now available and in place. But there is also some discussion about using the security guards just to break people's habits and give them some reminders. So what we find is using behavioural science does help with the evaluation, because it's easier to measure or identify components of the intervention due to the behavioural specificity and that diagnosis that we engaged with right at the beginning. And when we work with theory, and the Combi model is underpinned by several psychological and social theories, it helps us to understand those mechanisms of change. We know what is changing, but you also know why it's changing. And also it does, evaluation it's good to tell us what works well, but also it's helpful to inform further changes that may be required or what hasn't worked so well. So what we recognised were that there were some budgetary constraints, which meant some of the healthcare professionals were improvising in terms of hand gel, and they would use containers that may have been confused with some drinking water, and also the concentration of the alcohol wasn't quite right either. So again, the evaluation revealed that we've increased knowledge, but there's more to do in terms of some of those skills developments. So just in summary then, behavioural science provides an evidence-based process in terms of how to identify behaviour change, and I'll just jump to that final point there, because the process is clear. I want to really reinforce the emphasis on partnership working in terms of being key to achieving this. So incorporating behavioural science along with medical doctors and the pharmacy staff and the administration staff really enhanced the the way in which we could tackle the complexities of antimicrobial stewardship and a far more effective approach with multidisciplinary team working. Thank you.
Thank you, Atiya. Can I ask our panelists all to turn their videos on and microphones for the Q&A session? We've got our first question here, so this is to everybody. Could you discuss what more we can do in Cambridge and the East of England region to build on antimicrobial resistance projects in Ghana and Uganda? And could you share, and how could we share learning across these projects, both in partner countries and in the UK?
Okay, I'll go first.
Okay.
So I think for me, in terms of, so I'll tackle the involvement first. One of the things that we're finding now is that the hospital that we're dealing with in Ghana especially has got lots of data, and the interpretation of that data is actually key for implementing certain changes, or at least highlighting things that needs to change. So involvement for me will be get in touch with organizations like Cambridge Partnerships, CPA, Commonwealth Pharmacy Association. Look for opportunities around the East where you can get involved, and the involvement doesn't necessarily have to be even traveling along with them or anything like that. It could be just being around for data analysis support, or interpretation of data, moving forward from that. In terms of learning, there's, for me, it's understanding what partnership is and was, and how it can be moved forward, even in challenging times like COVID times, is one of the biggest highlight for me, and it's something that I'll carry on moving forward as well. Thank you.
Thank you, Edwin.
Thanks. Yeah, I'd agree with those comments. Actually, I think that one of the key things is that, well, I think the key thing is that we can learn together. I think, as I mentioned in my talk about the global health fellowships that we're trying to establish within the East of England, which I think will initially be for doctors, but I think there's no reason why that can't go well beyond that. And I think that you've seen this with the Chief Pharmaceutical Officers Global Health Fellowship Scheme, that there are going to be these schemes where people can get much more involved with the partnerships for a longer period of time, which I think will greatly enhance their ability to work with partners overseas. I think also we need to, we were hoping to host our Ugandan partners again within Cambridge. I think the learning has to go both ways, and I think that's very, very important going forward. And again, we've also got a lot of data that still needs to be analysed, and from our partnership work, which has all been put on hold. So there are likewise many ways that people can be involved with the partnership that doesn't necessarily require people to go out to Uganda. And then I think that one of the strengths of Cambridge Global Health Partners is that you can bring the partnerships together, and there can be shared learning across the different disciplines. So I'm doing some teaching tomorrow actually with another partnership scheme that Cambridge runs within Myanmar. And I think this is because we can kind of work together with all the different partners that people are working with, and we can kind of work together in different ways. So there are different ways we can do it, which can be coordinated through the Global Health Partnership Scheme.
Fantastic, thank you, James. Atiya, just a question for you about behaviour change. It's key, not least in a pandemic. How do you think UK public health can learn from these partnerships? We seem to be struggling here to change our behaviours when it comes to hand hygiene and mask wearing and so on.
I think the partnerships offer really nice examples of how you can work together to get the message across. And so what we can do within the UK to support during the current pandemic, I guess, is to connect with our communities, to have closer partnerships between organisations, whether that's a local authority, the health, healthcare organisations, and community partners, and to be more actively engaged, so that the message will reach the communities, so to increase people's knowledge, but so that it's localised and relevant, to recognise people's local barriers, local facilitators, and then also to help them with their decision-making process in terms of whether or not hand hygiene or mask wearing has a positive outcome, but using, again, language that's accessible, stories that are relatable. So, and the partnerships do that. The partnerships are key. Our partners abroad, our partnerships within our teams and organisations illustrate how that can be done and how we can change behaviour. And I think that's how we can transfer some of that learning.
Thank you very much. I want to open up the questions to the audience as well. If anybody has a question, please put your video on and unmute yourself. I can see here.
There's a question from Sarah. Oh,
great, thank you.
These partnerships are clearly cost effective, and how can we influence politicians and help them see? Well, actually, yeah, so not so much here, but in Ghana, what we were doing became part of a national platform for AMR surveillance. And we made sure that whatever we were doing in terms of action plans, meetings, and notes from meetings were pushed through to the higher AMR platform, as it's called in Ghana. So, and that went through to the Ministry of Health. So for me, I would say it's making sure that the activities and the outcomes are being shared, as well as being published, but are being shared through the right channels to the influential people within the community, both locally and nationally, as we did in Ghana.
Thank you, Edwin.
So I can comment on that as well. I think there was, so within our partnership, I think you saw a slide of one of our infection control nurses, Chris Moody. He was very involved with the Uganda partnership last year. And I think that the benefits go very much both ways. And she's been absolutely central to our local response to COVID within Cambridge. And I think that she would say that a lot of the things that she's put into place with COVID, she gained some of those skills through the partnership. So I think the benefits are huge for the NHS itself. And I think that the experience of people who went out to Uganda and worked within the partnership, we've been seeing the benefits of that very recently with COVID. There's also a question from Elizabeth Brooks about veterinarians and working with them. It's a very good question and a very good point. And I think that, our partnership has been very much focused on obstetrics in a neonatal hospital. But we've got discussions with academic colleagues in the university about trying to build in a research agenda. And one of the areas we want to look at is how the drivers of antimicrobial resistance within the community beyond the hospital, and veterinary practice is absolutely essential for that. And the kind of zoonotic animal-human health interface is going to be vital. So I think that I think it's really important that we keep the clinical infection control antibiotic stewardship activities going with the partnership hospital. But beyond that, we want to expand the research agenda, which will look at these wider issues.
Can I just add to what Jamie's just said as well, is within one of the partnership, they actually took a One Health approach. So they actually went into the community and spoke to kind of people about their farm animals and so on. So they did, not all the partners did, but this particular one actually took a One Health approach, and they did look at aspects of animal care and the impact on stewardship as well. So there are ways we can all look at it from a One Health perspective. It depends on where the setting and where it starts from. One of the things that we're looking at moving forward for the next project for the partnership is really involving the community and how antibiotics are being used to care for their animals as well. So there are definitely a veterinary aspect to that we can all look and approach.
Thank you, Edwin. And we have the privilege of having Dame Sally Davies with us today in our session. She's just put on here the Wellcome Trust new strategy may help on funding. Does anybody want to comment on that?
Yeah, thank you very much. I have actually seen that, and we've got a discussion with one of our academic colleagues that I did my PhD in Vietnam, and I used to work with him in Vietnam, and he's funded by the Wellcome Trust, and we're going to be discussing with Evelyn actually some of these research ideas and how we can look for funding. So thanks for the suggestion. We'll look at that in more detail.
Thank you. It's time to end our Q&A. Thank you so much for joining us today, and I'm sure you'll join me in thanking our panelists as well. It's very inspiring to hear about the collaborative health partnerships and your contribution towards preventing global antimicrobial resistance. So thank you so much. Just in terms of admin, if you leave this Zoom room, the portal for the main session will be put on the chat now. So if you just click on that link, you can go back to the main session. Thank you so much.